Yeah, welcome to the CTSI seminar for today. My name is Karen Rui. I'm very happy to be the host today for Philipp Scherer. I want to tell you a little bit about Philipp. He's currently the director of the Touchstone Diabetes Center at UT Southwestern Medical Center. And a little bit about his background, which is very interesting. So Phil got his PhD at the University of Basel, Switzerland. And it's there that he actually worked and identified several components of the mitochondrial protein import machinery, which I didn't realize. He then went on to MIT in the Lotus lab for his postdoc. And I'm very familiar with the work he did there, which largely involved identifying protein factors that are secreted from adipocytes. And what's very well known is that he identified one of the first adipocyte-specific secretory proteins, adiponectin. And I think it's this work really has strongly influenced our thinking about adipose tissue as an endocrine organ. I think it's very impressive. I noticed from his CV also that he has an R01 grant focused on adiponectin that's been continuous for the past 25 years. So there's still apparently a lot to learn about adiponectin. Following his postdoc, Phil joined the faculty at Albert Einstein College of Medicine, and then ultimately moved to his current position at UT Southwestern. And I think that what's notable to me about his body of work is that it's really shaped our thinking and our understanding of adipocyte function, both in health and disease. And he continues to study how adipocyte-derived proteins serve as links between adipose tissue and other tissues, such as liver, pancreatic beta cells, and so on. And these have major influences on energy homeostasis, inflammation, cardiovascular disease, and even cancer. I should note that Phil has really received numerous accolades throughout his career. Without making a long list, I can tell you he's received all of the top awards with the name diabetes in their title from across the world. This includes the Banting Medal from the American Diabetes Association and major international diabetes prizes in Europe and Japan and so on. And so we're really happy that you're here today. Thank you. And we look forward to your talk.
Thank you, Karen. That's a very nice introduction. Let me see, trying to advance the slide. And it doesn't. Oh, maybe I used the keyboard. That's another. There we go. All right. So it's always a pleasure to come to campus. I think UCLA is probably the single densest concentration of people working on metabolism on the West Coast for sure. And I think it's always good to see how much activity and how much coordinated efforts are going on here on campus. So it's a great honor. Inter-organ crosstalk. I am in my usual fashion try to cover over a couple of topics over the next 45 minutes to show you basically how incredibly powerful the underdog in metabolism really is. And we still look down on adipose tissue to some extent as just flubber. But I think the last 2 decades have clearly shown us that if there's somebody in charge within the system as far as metabolism is concerned, it will be the adipocyte and basically telling the brain what to do in that sense. So it's a big pleasure to bring my dancing fat cells here to campus and educate you about the systemic impact of the adipocyte. You all know these graphics basically from the CDC in terms of the obesity and the rate in the US. This is a 2-dimensional map that you have seen as well over the years, where you superimpose diabetes with obesity. And you can clearly see that the two of them go hand in hand, and the whole nation turns more and more purple as we go along, emphasizing again that the underlying reason for a lot of the conventional sequelae that we think about, diabetes, cardiometabolic disease, and also cancer, basically have an underlying basis in excess adipose tissue expansion. So naturally, we all think of the fat cell as being a critical driver for conventional metabolic related questions. with the critical players, of course, being in the pancreas with the alpha and the beta cells, but then many other related cell types and tissues as well in the liver. But the other thing that we need to really also bear in mind when it comes to metabolism research, and I noticed you have some upcoming speakers in that area as well, is cancer metabolism. And cancer metabolism stretches, of course, to the basic fundamental ways by which a cancer cell gains its energy. But what I'm trying to say here is this is about the microenvironment and the systemic metabolic milieu that a cancer cell is exposed to and takes advantage of in this context, which is equally important. And what is striking, and I'm usually running a group meeting, journal club Monday mornings for the Touchstone Center, where I just try to summarize all the relevant papers that came out over the last week or so. And this one was actually in there this Monday. That is quite amazing. This is a paper from Diabetic. It's an epidemiology paper, but it makes the case, talking about metabolism and cancer, that in type 2 diabetics, the increasing concern is that they're not going to die of, as we used to think, exclusively of cardiovascular disease, but there is a definitely strong cancer signal built in the type 2 diabetic patient as well. And we need to understand the underlying connections there a little better. It's not just about hyperglycemia, and it's probably not just about chronic subclinical inflammation. We don't understand fully what that means. And then also in the context of infectious disease, historically, my lab has had an interest in parasitic infections that hit the fat cell. Trypanosoma cruzi is one of those parasites that loves to reside in fat cells. This is the causative agents of Chagas disease in the heart. But now more recently, I think we've also appreciated the fat cell as a target for viral infections across the board, and most relevantly in the most recent past, of course, with COVID-19. And again, this is a paper that we discussed this Monday that just came out on SARS-CoV-2 infection and adipocytes. So these viruses do infect adipocytes as well. This just happens to be one of the groups. We had Tracy McLaughlin at Stanford and others that sort of argued along the same way that these viruses can infect fat cells and lead to chronic disturbances within adipose tissue, which is particularly relevant nowadays that we think a lot about long COVID and some of the sequelae of COVID that carry on beyond just the fuzzy brain and the systemic, tiredness that people perceive, but the increase in the number of type 2 diabetic cases that has now emerged post-COVID, perhaps as a direct consequence of viral infections. And that has major public health implications as well. So all the more a reason to better understand the adipocyte, which is really at the core of this whole operation. And traditionally, we grew up in this area where in this era where we thought that the fat cell is a terminally differentiated cell. It really doesn't have too many options than basically grow in size, or it can shrink in size when we go on the diet, or it can just necrose, apoptose, and leave a lipid droplet behind, which then gets cleaned up and causes some local and systemic inflammation. But we have certainly learned over the years now that fat cells have more options. They can actually undergo a very well-defined de-differentiation program as well. We used to think that's not possible, but with conventional pulse chase labeling methods that actually Annabelle Wang, who is here in the audience up front from City of Hope, she pioneered these studies doing lactation, for instance, in a very physiological setting where you paint existing fat cells, in this particular case in blue with a lac-C, and then you let the mouse get pregnant and you analyze what's going on. You see that the fat cells slowly disappear as the milk globules sort of emerge. And on the right-hand side, you have actually fibroblast-like cells that hang around, but they're still blue. That means they derived from mature fat cells. And they sit there, they actually single cell sequencing suggests those are fully de-differentiated fat cells. And they, during involution, when lactation starts, the fat comes back, and the very same cells that underwent a complete de-differentiation undergo redifferentiation now and come back as blue cells in this context over multiple pregnancies. So this is a sort of yo-yo effect over multiple rounds of gestation, and most, even after 3 pregnancies, most of these fat cells still remain blue. So this merry-go-around of lactation, where I found now a final use for our cartoon that never made the cover, that is a differentiation, redifferentiation of these fat cells under very normal physiological conditions. It turns out you find this phenomenon everywhere you look. In the skin, the dermal adipocytes undergoes a highly synchronized de-differentiation and redifferentiation. Of note, the dermal adipose tissue is not the subcutaneous adipose tissue. We have to distinguish that. This is that thin layer that you see in the dermis here. Just a few fat cells stick, but very important for hair follicle cycling, for wrinkle formation. It is the first antibacterial barrier that we have, and it can expand in certain mouse models, as you can see here. But during early development in the mouse, there is a highly synchronized de-differentiation and redifferentiation of these fat cells going on as well. And we'll find a similar non-synchronized phenomenon in humans as well. Now, in the skin, this thing can actually go bad and get on a bad track when you have a chronic stimulus like irradiation, sclerosis of the skin in general. These fat cells then not only de-differentiate, they can actually morph into really nasty myofibroblasts that then are responsible for the profibrotic program that you see in the skin under those conditions. And it was at that time when we tried to be cute and coin the term AMT. This is the adipocyte myofibroblast transition in analogy to the EMT that you get in cancer, which is the transition to a more metastatic growth in this context. This holds true even for adipocyte-like cells in the lung, for instance, or for that matter in the liver. The stellate cell, very much along the same lines. The stellate cell can become activated and be highly profibrotic, even though the quiescent stellate cell or the quiescent lipofibroblast in the lung has PPR gamma. He has the classical adipogenic marker, has adiponectin, has other components. They can turn into myofibroblasts, and under a number of different conditions, we refer to it here simply as idiopathic, but again, highly relevant in the context of lung fibrosis in COVID-19 as well, that they become very fibrotic cells and actually are responsible for this severe deposition of extracellular matrix in the lung. And again, we've been thinking of ways by which we can counteract that in the sense that we can activate PPR gamma again and try to reverse some of that myofibroblast differentiation back into lipoblasts. And at least in the preclinical model, that seems to work quite well. Another thing we can do in the lung, we can target specific factors that are profibrotic, that derive from the fat cells originally. In this case, we actually targeted leptin, and we've developed a neutralizing leptin antibody in a model of lung fibrosis that some of you might be familiar with. This is a bleomycin inhalation model leading to massive widespread fibrosis. And you can see here the trichrome stain. You see the dark blue stain here. And when we treat, in this particular case, with a neutralizing leptin antibody, you can actually see a dramatic reduction in the fibrosis. So the lipostatic leptin factor that we all think of it as acting primarily on the brain has a very important role in the periphery, is actually a potent profibrotic factor, and neutralizing of which can actually be potently beneficial in this context. And we are ongoing experiments with promising or preliminary data in the context of COVID-19 infections in a mouse, with the neutralizing antibody alleviating some of that lung fibrosis. And you can see here, this is the control antibody, this is the leptin antibody, inflated lungs here, dramatic improvements histologically as well as functionally. Similarly, in cancer, in breast cancer, we have a phenomenon where we can paint the existing fat cells and watch them de-differentiate as the tumor lesions invade the mammary gland and take over. And this happens both in the mouse, you can see in clinical H&E stains as well, that the fat cells disappear as the lesion invades. Basically, there is a high degree of lipolysis going on in these dedifferentiating fat cells. And again, if you look at the previous slide here, we can detect that these pre-labeled fat cells here in pink end up in punctate kind of fibroblast-like cells. And again, you can do the single cell sequencing on these isolated cells, in this particular case labeled in a different way. And what you end up seeing is actually quite dramatic, a full differentiation of fat cells again, but they turn into all kinds of things. Not only do we see the formation of classical pre-adipocytes when they go back, we see the presence of myofibroblasts again, which are responsible for the fibrosis. And we see even macrophage-like cells that derive from the mature fat cells. So I emphasize macrophage-like cells because this is a very unconventional way to become a macrophage cell, and a bit heretic to claim this as a pathway. But those are cells that derive from the mature fat cells and express basically a gene expression pattern very reminiscent of an M1 type macrophage as well. The question then is, what drives some of these sort of events, this fibrosis, that dedifferentiation? I want to introduce you to this fellow here called endotrophin, which again, we discovered probably about a dozen years ago as an adipocyte-derived factor that is being released both in vitro, in tissue culture, as well as in vivo. What makes this a little unusual, it's not a gene by its own. It's actually a cleavage product of an existing collagen 6, which is the most important glue that holds our fat together. And that is the C5 domain of this collagen 6 alpha 3 that has pretty much a life of its own after biogenesis in vitro, and is released into the extracellular environment of a dysfunctional fat pad at much higher levels than in a functional fat pad. So you can see, for instance, this is a human breast histology of without any cancers there. This is a normal stain for endotrophin, very low levels, whereas a fibrotic breast tissue, which has epidemiologically a much higher chance of eventually developing a tumor, that one abounds with a lot of endotrophin in that microenvironment. When we look at other clinical samples here in collaboration with my colleague Sam Klein at WashU, you can actually see he has this wonderful collection of metabolically healthy lean, metabolically healthy obese, and metabolically unhealthy obese individuals. And these two here are matched for BMI, but the healthy ones have obviously better insulin sensitivity, and they are by all criteria, quote unquote, normal, whereas the unhealthy one have all the associated insulin resistance and inflammation and fibrosis, for that matter, in their local microenvironment. And you can see a wonderful sort of correlation between the levels of endotrophin that you find not only in circulation, so this is a factor that can be released and you can measure it by ELISA in circulation, but it also acts mostly locally. And we can see here in terms of plasma measurements that the ones with the highest levels of endotrophin have actually the worst metabolic parameters across this as well. And we've seen this also in preclinical models where we actually simply overexpress endotrophin without the parent molecule, and that alone can cause fibrosis. Pretty much everywhere we have an excess of endotrophin, creates fibrotic adipose tissue as well. This is a factor which intrigued us also in the context of breast cancer, because we could see here in this paper as a follow-up of the original data that there is a lot of qualities that we don't want, which are built into this endotrophin. It's pro-fibrotic. It's a chemoattractant for immune and endothelial cells, and it stimulates this EMT, which basically is synonymous with enhanced metastatic growth and chemoresistance, basically, in tumor cells. So it really is a quite nasty fellow in this context, and just neutralization of endotrophin alone. So we developed here neutralizing monoclonal antibodies against endotrophin. And you can see here with that neutralizing antibody referred to as number 4 here, we have in purple a very stark reduction of tumor growth simply on the basis of neutralizing the endotrophin molecule in the microenvironment. If we were to add on top of that cisplatinum, breast cancer cells conventionally will be highly cisplatinum resistant. When we neutralize endotrophin, we actually dramatically enhance the susceptibility of these breast cancer cells to chemo intervention. So this is a very exciting and very active area that we are pursuing. But because it's so pro-fibrotic, of course, when you think of fibrotic tissues, but the liver is sort of way up there, liver fibrosis. We've used these neutralizing antibodies with a number of different models. Michael Caring heard my talk a little, couple of years ago about this, and argued that our models are useless and we need to really do this with his model here, the MUP-UPA. This is an ER stress model that you probably know of. And I must say, it's actually quite a good model and probably has even some clinical relevance as well. When we look at this, we can actually see that the neutralization of endotrophin in this setting dramatically reduces inflammation. It dramatically reduces the degree of fibrosis as well. And with that, we can also see improved liver function overall, and eventually even a reduction in the generation of hepatocellular carcinoma lesions in the liver as well. So that's certainly working well in the liver. We can take this to the kidney. We can go down the list of fibrotic tissues. Diabetic nephropathy, classically very rich in extracellular matrix accumulation. And we see basically the same thing in the kidney cell. We see a reduction in various extracellular matrix components here that you can see in the presence of this neutralizing antibody. We can see this is a podocyte insult model that we developed a couple of years ago. And we can see the functional regeneration when you compare here control antibody versus the endotrophin neutralizing antibody. And this goes hand in hand with a complete functional reconstitution of the liver insult in this context as well. And this paper, I haven't updated it, just came out a couple of days ago in Molecular Metabolism. Most excitingly, remember we started out with a factor derived from fat cells here. Now the cardiovascular field has discovered endotrophin as well. This is a large study from SmithKline with some of the folks at UPenn that were interested in HFpEF. So heart failure with preserved ejection fraction, for which there wasn't really a marker. I think SmithKline was studying at the time, no connection with them, by the way. This is just reading their paper. They used, I think, SGLT2 inhibitors and looked for a marker that would gauge their effectiveness. And you can actually see that when they measure endotrophin in circulation, that this is by far the best marker for HFpEF to start out with the primary endpoints in mind, in their case, overall death or heart failure admission. This is better than any clinical marker that they've looked at. And you can see the mortality rate when you have the classical tertiles in terms of endotrophin levels, that the higher the endotrophin levels, the higher the mortality rate overall. So what that suggests, which we were saying for many years, but no one was listening until Big Pharma gets involved, that this is a really potent marker for a lot of different disease states. We would call it basically a fibroinflammatory marker that you can pick up in circulation as an indicator of the relative stress on the system. Now, that can be cancer, that can be cardiovascular disease. And you see this paper here, chronic multimorbidity and all-cause mortality in elderly women here as a marker of that. So that's an impressive sort of correlation that you see out there at the clinical level. And we believe that this is actually more than a correlation. We believe as a biomarker, very powerful, but as an interventional target in cancers, very potent, where we know preclinically that both breast cancer, hepatocellular carcinoma are prime targets, but it stretches on. As an anti-fibrotic factor, it's about as good as we've seen things happen. You know that neutralization of TGF-beta is not trivial and has a lot of side effects. Here, we seem to be tapping into this fibrotic axis in a more benign way and actually reduce it in all the tissues that we've looked at. And we believe this really has quite a potential for future development, perhaps the lowest hanging fruit in the area of fibrosis, simply because we don't have too many options out there in terms of anti-fibrotic actions at this point. But I want to also emphasize this is almost distracting us a little bit from the fat cell. Remember, it is the fat cell that originally led to the discovery of endotrophin, but endotrophin then popped up in a lot of different other settings that don't necessarily invoke the presence of a fat cell. So frequently cancer cells, macrophages, hepatic stellate cells will be a source of endotrophin as well in the local microenvironment. But it certainly helped us understand and get to that point by studying the dysfunctional fibrotic adipose tissue in general. Now, my colleague Christine Kuzminski has written this a couple of years ago. It's time for an update on that, but this is about 6-7 years ago. Adipose tissue as a discovery source for interesting targets that we could go with. Endotrophin will be one of these targets, heavily studying leptin as another target that we can neutralize. I've shown you the reduction in fibrosis in the lung with leptin neutralizing antibodies. So both of these targets can easily be neutralized to some extent, and we can reap the beneficial effects downstream of the neutralization without really causing any notable toxicity. So Christine many years ago manipulated fat cells in a number of different ways. She made the models initially of metabolically healthy obese mice. We still hold the world record for the fattest mouse ever. These were the equivalent of 600-pound patients out there, but they are metabolically healthy. They expand their subcutaneous fat mass, and by all criteria, these mice, if it wasn't the fact that they're so big that they become very immobile, they are actually, in terms of the parameters that we can measure, quote unquote healthy. That's not an endorsement for obesity, because people always like to argue about that. Healthy obesity, should we talk about healthy obesity? I don't know, but there is such a thing cross-sectionally where people have excessive amounts of fat tissue and they're perfectly fine with it. It's the exception, and they're still at higher risk to fall off the cliff at some stage. But cross-sectionally, this is possible by neutralizing all excess calories, putting them into your subcutaneous fat, where they do no harm, basically. And there have been a couple of different models over the years where we can sort of really show that, with litamates that, there is quite a bit of size difference there. There is more to it, though, than just the adipocyte in adipose tissue. And again, the original extra fat mice were generated by manipulating the relative iron content in the mitochondrial matrix of white adipocytes. We slow down oxidative phosphorylation a little bit in a very physiological range. We can use similar approaches in many other cell types within adipose tissue. For instance, precursor cells. Here in this collaborative effort with Rana Gupta's lab, again, we manipulated the mitochondrial activity of the precursor cells. And those of you who follow the mitochondrial precursor field a little bit realize that we have different kinds of precursors. We have so-called FIPs that are fibroinflammatory, nasty precursors that have the ability to turn into fat cells as well. And then there's the classical adipocyte precursor. Nomenclature is a bit of a mess out there at the present, but nevertheless, manipulating oxidative phosphorylation at the level of the precursor cell, we can very effectively manipulate the fate of these precursor cells as well, and have potent beneficial effects not only on the fat path, but also systemically. And then, of course, we have macrophages. This is a macrophage stain. So this is a lipid droplet surrounded by a macrophage. And I actually cut some of the slides because I thought I only had 40 minutes here, but I think we have a few minutes. So I just want to show you the paper because it just came out a month ago or so, that manipulating the metabolism of macrophages in adipose tissue has very, very potent effects as well. So this is about this admittedly naive distribution of M1 versus M2 macrophages. Obviously, reality is more complicated. But the fact is that when we reduce the oxidative phosphorylation capacity of the macrophages in a physiologically meaningful way, we can actually divert many of the M1 macrophages or monocyte commitments to the M1 lineage towards the M2 lineage and achieve beneficial metabolic effects overall. You would argue when we manipulate both the precursor cell as well as the macrophage here, those are systemic manipulations. So how do we know this is about the adipose tissue macrophage and not about a macrophage somewhere else or something happening in the brain? In both cases, we can actually transplant the phenotype with adipose tissue transplants. And I'm still, after playing this game for 25 years, I am still in awe about the potency of fat transplants, where we take as little as 200 milligrams of fat tissue that either has a negative or positive effect in the original mouse, and we give it to a wild-type mouse, and we can actually transplant the phenotype with that little adipose tissue. We can do it with fat cells, as you will see. We can do it with macrophages manipulations in that area, or with the stem cells. Many times, this is very, very powerful, and still somewhat of a mystery how such small amounts of fat have an imprinting effect on the entire system. Now, if we go back to the lean and healthy mice here, I can't resist but tell you a little bit of a story which is very recent, which is still in development, but the effect sizes that we see in that last model here are actually quite amazing and still blow me away at this point. We live in the era of dual agonists at this point. So the most effective way to lose weight at this point is to be on a GLP-1 receptor agonist, such as liraglutide or something equivalent of it, or more recently on a dual agonist that takes advantage of both GLP-1 receptors and the GIP receptor. And clinically, this is very exciting because it's been approved, at least for diabetes and now obesity as well, in the sense that the average individual that goes on the drug can lose up to 20% body mass total, and this is all mostly about fat mass, with what most would argue relative minimal side effects. So I think that really revolutionizes the treatment of many different diseases, not just obesity, but everything else that comes with it. You lose 20% of your body weight, your fatty liver is going to resolve, your cancer risk is going to go down. You can watch the old Swedish SOS gastric bypass study where they have morbidly obese individuals that lost that much weight, and every single parameter improved. Some of it will stay. We still will have a fibrosis issue. We will still have other issues. It doesn't solve all the problems, but it's a major step forward. The question is, how do these drugs really work? Obviously, there's a very profound interest in the mechanism of action, and the GLP-1 receptor axis is somewhat a little bit ahead of the GIP receptor axis in terms of our understanding of what's happening. So us being, of course, very adipocentric in our views, Christine decided that with her folks to start to overexpress the GIP receptor at the level of the adipocyte. And we do this in the classical way we do most of our things. inducibly in the adult mouse, and we prefer the doxycycline system. Has its shortcomings, but it's the best system I see out there, much better than tamoxifen or anything else. And we can dose the induction very proportional to the amount of doxycycline we add into the food. And we have now a mouse that overexpresses the GIP receptor in its adipocytes very, very selectively in this context. And we can turn it on and we can turn it off, and we can ask what happens. So you can see here with that dancing fat pad that compared to the wild type cells in this exposure, you can't really see it. They do have GIP receptor expression as well. I know this is controversial in the literature, but they do have it there both in human as well as in mouse fat. And we overexpress it, of course, now in the adipocytes. And you can see that here on the right hand, perhaps a little better with a more static picture for the GIP stain in the fat tissue. What happens when we induce the GIP receptor in a lean mouse to start out with, you see that in red, the mice compared to the control mice gain a lot less weight here. It's quite dramatic. And we can dose this down. We can use much lower doses of the receptor, and we still get the same, almost the same bang for the buck, in the sense that we have a reduced weight gain in this context. We have seen that with a couple of different models in the past. And usually we get suspicious when that happens, because what it means is that we are screwing up fat, we cause fat lysis, and this is a lipodystrophy model. This is not a lipodystrophy model. A lipodystrophy model would have a liver that will explode from steatosis. This model doesn't have hepatic steatosis. So these are fully functional fat cells, as you will see. When we do this with mice that we fed a high-fat diet for a long time beforehand, and we start to induce the receptor in the adipocyte, we can actually not only see a further reduction in weight gain, we see a very dramatic weight loss here, 30, 35% ongoing if we wanted. We had to sometimes stop that. But again, not a lipodystrophy model in this particular case. The fat looks just fine. It's actually, its level of inflammation is quite reduced when you do the analysis, and realize I don't show you most of the data, but we are looking at very skinny, very healthy fat pads in this particular context, not lipodystrophy. Is it beiging? Well, those of you who would sort of argue, not really, there isn't really that much beiging going on apparently here. And indeed, when you do the same experiment at thermoneutrality, the mice still fail to gain more weight. So this is not about excessive energy expenditure through mechanisms of beiging. We can, in fact, actually fully reproduce the effects that you see with a GLP-1 receptor agonist or a dual agonist by simple overexpression of the receptor in the adipocyte. What happens with these agonists systemically is that you have a transient suppression in food intake, which then bounces back and normalizes. And this is not liraglutide, this is the receptor overexpression, but we can phenocopy the entire phenomenon by simple overexpression of the receptor in the adipocyte. And you can do this both in lean, and the same holds true for obese mice. So massive drop in food intake, which then comes back to starting levels. And note, this is not normalized. This is absolute food intake per mouse. So technically speaking, these mice are actually hyperphagic because they have lost a lot of weight in the meantime, as you can see under those conditions. And you can't not reach the same degree of fat loss and body weight loss by pair feeding these mice at the same time. So this is not just about food intake. There's got to be more to it than that. Central effects. Yes, there is a central effect. And remember, we tickle the adipocyte here, and the brain responds. In this somewhat beautiful but totally meaningless movie, you can actually see as the brain lights up by C-phos stains on the right-hand side in an acute induction of the receptor in the fat cell, the brain lights up and like a Christmas tree, so it's beautiful to look at. But when you look at this more specifically as a function of time, you can actually see here at 24 hours how the receptor induction happens in the brain, and it persists afterwards as well. But when you do the differential down here between the wild type and the control, you can actually see that there's a lot of unique regions that are either up or down regulated as judged by CFOS by induction of the GIP receptor in the adipocyte. Now, we cannot, as I said, pair feed or 50% food restrict these mice to the same extent. They are not going to lose as much weight. In red, you see the receptor. In blue, we have the 50% calorically restricted wild type mouse, doesn't lose quite as much weight. That suggests we have increased energy expenditure, and without dragging through the metabolic cage data, yes, oxygen consumption is up. The respiratory exchange ratio goes up, lipid oxidation is up. These fat cells soak up lipid like crazy. They also soak up glucose as much as they can in this particular context. And you can actually repeat this in a seahorse experiment here, where you can see this dramatic increase in mitochondrial respiration in fat pads, fat pieces from the transgenic mice versus the control mice. So quite an increase in overall energy demand of these fat cells, which is intriguing, and this can be represented in this graph as well, where we have both the fatty acid and glucose need dramatically increased there. So the question is not only how do we achieve that, but what's going on once we stop the expression of the receptor? Because we know already anybody who's been on a liraglutide or on a tirzepatide, when you stop, your weight bounces right back. So we have no way of maintaining that lower weight. What is intriguing, and we've seen this now over and over, we need to have the receptor expressed for a certain minimal amount of time in the mouse, approximately 5 to 8 weeks of GIP overexpression in the fat. If we were to show you the rebound effect of a caloric restriction, it would immediately bounce up. But here you can actually see that these mice, which are by all accounts wild type now, they have no longer receptor expression, they maintain that lower body weight. So we have something, we changed something in the fat of these mice permanently, and kind of change the lipostat, if we want to refer to it like that. There's no beiging and no browning going on. There is no change in locomotor activity. It's not that these mice run around like crazy there and expend their energy like that. And then the obvious other one that is sort of the Spiegelman model here, the creatine phosphate cycle, which is another futile cycle. And we tried very hard by all accounts. No evidence that the creatine phosphate cycle is involved. With all the omics we could put our hands on, and basically, again, a year worth of digging sort of reveals this, that something is going on with calcium signaling there, because all the top hits that were changed in RNA-seq, as well as the proteomics, and the metabolomics, it all screamed is something to do with signaling. And it ends up, the culprit actually, or the mediator, is basically a new permutation of the old circa pathway. So this is a pathway that's been well described in muscle for non-shivering thermogenesis. This is the calcium import into the lumen of the ER. And it is well established that in muscle, as well as in beige cells, beige fat cells, you can have futile cycling of calcium, which can not translocate, but just basically consume ATP and basically expend energy in that fashion. And that's exactly what's going on in this particular model as well, even though novel components are involved in it. So it's not something that has previously been known to even exist in the right adipocyte, but it's extremely effective in this context. And one of the markers that is very diagnostic for this pathway is sarcolipin. This is one of the proteins here that mediates this effect back here. And both SERCA and sarcolipin are actually dramatically induced in these transgenic mice. And particularly SERCA2 here is quite significantly upregulated. And there is now plenty of inhibitor data as well that argues that when we inhibit that pathway, we lose that dramatic enhanced energy expenditure in these mice as well. And when we have that memory effect, when we go back to this period here, we can actually see that we have permanently induced higher levels of sarcolipin as well as of the SERCA component. So this, we believe, may not be the sole mechanism by which these mice have achieved a dramatic increase in metabolic rate, but certainly the major driving force basically for this pathway. So again, what this is aimed to do for you is really highlight the incredible power that we have by manipulating the adipocyte. Remember, this is a very simple manipulation. This is not a systemic administration of a drug. This is simply putting a little bit higher levels of a receptor into a cell type, the adipocyte, and asking what happens. There's a dramatic increase in body weight, fat mass, no impact on lean mass for that matter. In fact, the lean mass increases. Dramatic dependence on lipid uptake because it's constantly being burned, enhanced mitochondrial capacity in white adipose tissue, reduced inflammation and fibrosis. Uptake is increased. We have a transient reduction in food intake, which is not relevant for the long-term phenotype of the mouse, but we have a chronically increased energy expenditure. And that, we believe, is driven by a novel permutation of the SERCA calcium pathway. And we are very excited about the fact that there's a metabolic memory imposed on the adipocyte once we turn that factor off. So basically, the adipocyte, it de- and trans-differentiates into all kinds of cells. I would like for you to remember that. They can turn into friends, and they can turn into very nasty fellows out there. The myofibroblasts, we don't want them. Endotrophin is one of the factors that drives this phenomenon. Leptin is also a pro-inflammatory molecule in this context as well. We can manipulate iron levels. These are the very fat mice in the adipocyte, the precursor cells, the macrophages, where the metabolic fate of a cell determines its identity that it reaches at the end of the day. And you can see this pattern repeated over and over again, whether that's a stem cell in the classical sense, whether that's a T cell, whether that's a mitochondria, whether that's a precursor cell for the adipocyte, or whether that's a macrophage. We can drive phenotypes like that. And last, and perhaps most excitingly, the GIP receptor overexpression in the adipocyte as a very, very powerful way to change systemic metabolic parameters permanently in that sense. I realize, again, this touched upon a lot of different things here, but altogether, it's really supposed to highlight that this is a cell that can be manipulated and that we should reckon with in terms of having an influence on the systemic level. And I want to recognize everybody who's contributed here, including the GIP receptor overexpression is Christine Kosminski. Many of the other ones that are highlighted have been done by the current members. Thank my former postdocs that they all have their own labs now, including here Annabelle at City of Hope, and then my colleagues at City of Hope, at UT Southwestern that we interact with on a daily basis. Thank you. So if you have any questions, she's going to throw that cube at you. So.
Quick question, Phil. Since many adipokines, including adiponectin, have big differences between males and females, does endotrophin also show sex differences in these levels?
We have not examined this very systematically, but based on the clinical data that we see out there, there doesn't seem to be a striking difference in circulating endotrophin levels between males and females. No.
Hello. I just see the model of the this GIPR overexpression model. So have you checked about the insulin sensitivity? Because there are recent papers which is, have you seen in the calcium signaling molecules like S100A proteins, which I see seem to has been shown to have an effect on insulin secretion defects. So have you seen in this model the insulin sensitivity or insulin resistance? Whether for those models, do they have any kind of after the obesity or pre-obese conditions?
Very good question. I didn't go into that for good reason. So does insulin sensitivity get worse when you do this? No. Does it get much better? Does it get proportionally better to the amount of fat loss that we see? No. So the oral glucose tolerance test doesn't improve quite as much as we wanted it to see. We believe this is an example, and there are many examples out there where increasing energy expenditure does not necessarily result in improvements in insulin sensitivity. It's not worsening, and certainly the quality of the fat is better after the weight loss, but I'll be the first one to admit that improvements in insulin sensitivity would not be proportional to the massive weight loss that you see.
Okay, thank you so much.
Good point.
Nice. So it looked like your search for how the fat molecules were being utilized for energy expenditure led you to looking at the muscle tissue and the calcium transport cycling. You also saw there's upregulation of OXPHOS or oxygen usage. Have you looked at other calcium transporters like the ones involved with mitochondria?
Yes, we have. We haven't done functional tests, but certainly at the gene expression level, we don't see. We don't believe the mitochondria are a direct target for the GFP receptor expression. And we base that in part because we think if you do the seahorse on the whole tissue, we see the effects, but we don't see the effect on isolated mitochondria. So we believe that it's not a mitochondrial phenomenon per se.
Thank you.
Question? Okay. Hi, I'm wondering if you saw any changes in the ketosis pathways in your endotrophin or GPR manipulated models.
Good question as well. No, we don't see a major effect on ketone body formation, even though there's a much bigger dependence on lipid oxidation. Absolutely, but we don't see a difference on ketones. We do see a difference on branched chain amino acids, and at this moment, don't fully know what to do with that.